All right, we're right at 12:15, so I think we'll go ahead and get going here. Good afternoon, everybody. Welcome to our Project Echo session today on COVID-19. Thanks for being here. Big group today, so good to see you all. Yeah, some people are writing in through the chat. If you can keep doing that, if you just joined us, just sharing your name and your location for our records, that would be greatly appreciated. And then if you do have the ability to turn on your video camera, I'd like to ask that you do that. It's great to be able to see everybody, and it helps with some interaction. So I am Troy Jorgensen. I'm the program manager for Project Echo Nevada. If you're unfamiliar with Project Echo, it is part of the telemedicine pie is what we call it. So it is a telemedicine or telehealth program that originated in New Mexico, and we adopted it here at the University of Nevada, Reno School of Medicine in 2012. And really our goal is connecting providers, primary care providers, mental health providers, what have you, all across the state with teams of specialists that we put together here through the university. And really our goal is supporting you with challenging patient cases that you've had in the past couple of weeks, as well as we provide continuing education credit. So yeah, it's really just a great way of connecting everybody across the state who's got their own experiences and their own expertise and sharing best practices just connecting everybody across the state. Sorry, I'm not thinking very well right now. So we'll do some quick introductions of our hub team members. Dr. Krasner, do you want to start us off?
Charlie Krasner, I do infectious diseases at the VA and the university. And I'm here with Dr. Siddiqui.
I'm Faisal Siddiqui. I'm pulmonary critical care physician at VA Reno.
Dr. Krasner. And then Dr. Pandori, one of our other experts for today. Dr. Pandori, do you want to introduce yourself, please?
Hi, I'm Mark Pandori. I'm the director of the Nevada State Public Health Laboratory and an associate professor of pathology and lab medicine at the UNR School of Medicine.
Thanks, Dr. Pandori. And Jessica?
Sure. My name is Jessica Thompson. I'm an infectious diseases pharmacist at Renown.
Thanks, Jessica. And then our other ECHO staff member, Sneha.
Hi, I'm Sneha Sharma. I'm the program coordinator for Project Echo Nevada.
Sneha. And then Dr. Levine.
Good afternoon, everybody. Rafael Levy here. I'm the medical director here at Project Echo Nevada. Happy to see everybody. Just a quick plug for we have a case review form online, so if you guys want to pre-submit any questions, kind of like what you type into the chat, feel free to log on to our website and fill that out.
Thanks, Modi. All right, Dr. Krasner, you want to pull up your slides and get going here? So yeah, we'll have a quick didactic presentation from Dr. Krasner and Dr. Siddiqui, and then we'll open it up for questions at the end. And then, yeah, if there's a case that you want to run by our team, we'd be happy to hear that today as well. So Dr. Krasner, if you want to start sharing your screen.
Can you see it?
No, so you'll need to hit the little green share button on the Zoom toolbar.
Hold on a sec. So welcome, Charlie Krasner here. We're going to try to focus more on some clinical aspects and how to think about treating these patients as we've got more experience with them. So Dr. Siddiqui and I are more than happy to hang around after the talk for any questions we can help. I'm sure a lot of questions. I know Dr. Pandori's here and he's very busy, so I wanted him to maybe just talk about these first two slides. The first one is you can just sort of update us on how testing is going and how many kits you got, and review some of that. And then the next slide is about the interest in the using serologies. I heard an interview this morning on UNR, the radio station, where the medical director at Humboldt County was very interested in screening the population using the serology. So Dr. Pandori, if you don't mind talking first.
Not at all. Thanks, Dr. Krasner. There's an intercom above. I'm going to let that finish for a second. Okay. So the Nevada State Public Health Lab is one of about 4 or 5 major testing operations in Nevada. We've been testing since February 11th using a modified version now of the CDC's assay. The assay is a PCR test, detects virion particles. Our test ascertains for the presence of 2 parts of the genome of the virus, so has very high specificity. We are working 7 days a week to test for COVID-19, and things, of course, have ramped up in recent weeks, and we're testing anywhere between 150 and 320 specimens a day. Our capacity to test is about 400 a day. We are trying to obtain a piece of automation that will allow us to increase that throughput and to reduce the danger of repetitive motion to our staff. Like I said, we have about the capacity to run about 400 right now. We want to try to get that up to about 600 a day. Our inventory of tests is well into 6,000 or 7,000 range, and that's not really a concern for us at the moment. You've heard a lot of rumors and stuff in the media about lack of testing materials. And yeah, earlier on, there have been some components of testing that were in low supply, but we've managed to work around that with some policies that FDA allowed us to utilize to validate other materials. So yeah, we have testing capacity, and I think that will go into infinity. Where the problem has been with regarding to testing has actually been in collection kits. And so there have been quite a lack of collection kits out in the world, and that's a gray area. Sometimes the labs provide those to clinicians, and sometimes clinicians buy those themselves, and hospitals sometimes keep collection kits on hand. We're talking about NP swabs with viral transport material. So that's not available in the United States any longer. So what we started about 3.5 weeks ago here at the Nevada State Public Health Lab was a manufacturing process and a quality control process whereby we've been manufacturing collection kits and distributing them anywhere in Nevada to anyone that needs them in Nevada. They can be ordered through our website or to utilize where you can find a form to order them from us if you need collection kits. I don't know if that's too much detail, Dr. Krasner, but you can see here on the slide, this slide's a little behind. We've tested over 5,000 human beings here at the Nevada State Public Health Lab and have about 330, 340 positive results so far.
So you're right, this is from yesterday, you're right, so it's old.
Yeah, and yesterday was also a day behind. I just looked, and we're over about 5,057 tests today. 5,100 tests. So when we get things by 2 p.m., we turn them around on the same day. When they come in after 2, we're getting them around the next day. We did have a couple of days where they went a third day because we did get hit pretty hard with some big specimen volumes, but we've not had any instance where we haven't turned anything around in 3 days. We've done some environmental testing for public health, particularly in the outbreak at Willow Springs, and our assay does work to detect COVID-19 in the environment. I don't know if I'm hitting all the right notes you wanted, Dr. Krasner.
A lot of people are talking about this false negative rate. Can you give a little comment on that?
Yeah, well, first of all, like any viral infection, there's a diagnostic window period, whether for antibody detection or for PCR even. And that is the amount of time after infection that is required before the diagnostic signal is present. So for PCR, that would be detectable virus. For an antibody, that would be the time to detectable antibody. Serology, that would be detectable antibody. So what it looks like here is that, at least in one peer-reviewed study I got on my desk over here out of Singapore, was that some patients that are very early in symptomology, that would be like just fever, for example, are testing negative by PCR, and when they become more symptomatic over the course of the next 2 to 3 days, they become positive on the PCR. So a hypersensitivity to symptomology, or to, if you have access to testing by some means, and you are just recently symptomatic, it's very possible to be false negative. In this study that I saw, they followed 18 patients from the moment they became even feverish, and then PCR'd them every other day or every day for several days. And what was found was in 3 of those cases out of 18, they did get a first PCR negative. And those were people that were febrile, but not anything else. And we know there have probably been a few of those cases here in working with public health.
So you've seen some of those?
Yeah, I don't want to get into it, but we know
Okay.
that it's probably happened here. And so it's just that, you're going to want people to have been symptomatic for a couple of days to guarantee that you're getting a good test result. And we've known this for viral infections, but we just need to be reminded, and that's particularly true with serology, which I think was the other topic you wanted me to hit on. I don't
Yes.
know if I'm going on too long.
Yes, go right to the next slide there.
And I've never seen this slide in my life before, but I will do is talk about serology from what I've read in the
Please.
literature so far, and compare that to what we know. It looks like there's, I think, one or two that are now FDA cleared. Some of them are in the point of care format, and I think one's coming out in 96 well plate format. But these are IgM and IgG sensitive, which is to say that they would become positive, we believe, about 3 to 5 days after symptoms appear. So while PCR might give you a false negative at the beginning, these most definitely will if you test too early. And that it looks like IgM is coming up 3 to 5 days after the arrival of symptoms, which would be like a fever. And what we don't know is how well a positive result on an antibody test correlates to immunity. In cases like with SARS or with other coronaviruses, you can become positive on a rapid test, but the presence of your blood having neutralizing capability in vitro, as we say, that is your ability of your blood in order to neutralize virus in a lab setting, to infect cells in a lab setting, might not come for another week or two. But lab tests are pretty sensitive for antibody, and that might just be the case, or it might be a maturation of immunity situation. So from a diagnostic perspective, right now, I always look at testing through a medical lens or a public health lens, because I operate diagnostics at a public health arena. And so from a medical perspective, I'd have to caution about the use of antibody, because a negative result can mean what? It could mean you're not infected with COVID or with SARS-CoV-2, or it could mean that you're just outside the diagnostic window and testing too early. A positive result means what? It could mean that you had COVID-19 and now you don't have it, or it could mean that you currently have it, or it could mean that you had it transiently and mounted an immunological response but never were frankly ill. So using that test from any medical perspective, I would say is very difficult. The test will be extremely useful from a public health perspective, because what it will allow us to do is to gather what I call the intelligence of this whole thing. And that is how many people were exposed, and we didn't really realize it, because right now in what we might call wartime, we're really just testing symptomatic people and close contacts to symptomatic people. We're not generating surveillance intelligence. And that's why we really still don't know how many truly infected people are out there that might be asymptomatic. As the smoke starts to clear, these antibody tests will allow us to ascertain that, and they'll play an extremely powerful role in gathering that information through the public health lens. Now, some talk is occurring about using an antibody test to try to establish whether a person could go back to work and say, hey, I'm immune. And while with other viral infections, we might feel comfortable saying something like that, I'm not going to take a stance on this Project Echo call, but I will say that there isn't any data yet to support that person can't be reinfected, whether they can or can't. So I'm not really going to take that stance, but I'll say that we're right now in a dearth of data with regard to whether such an individual would in fact be immune. So asking such individuals to go back to the quote front lines is a topic that's going to require a lot of conversation, in my estimation. But I think
Can I ask you a question? This is Dr. Siddiqui.
Yeah.
Do you have an idea if we can utilize the IgG or IgM levels to figure out if the patient is ready to donate convalescent plasma?
I'm sorry, I didn't hear the last part of the question.
I'm asking if can you utilize IgG or IgM levels, probably IgG levels, to determine if a patient can donate convalescent plasma, because this is a therapy on the horizon right now?
No, there's no data for that. Generally, antibody tests are not very what you call analytical in a diagnostic perspective, which is to say we use those results in a more Boolean fashion. and we, not like viral load tests, which are more analytical. So it's going to be really like the CellX test, which is currently FDA cleared, is a test that tells you presence or absence of antibody in a binary or Boolean way. It's just whether a band is present or absent. So you're not going to get any quantitative data in that regard. And it's very rare for an EIA format to even provide analytical data with regard to antibody levels. So I'm not anticipating that becoming a tool for us.
Thank you, Dr. Pandori.
Sure. Was that enough or too much?
Yeah.
Probably. Thank you.
There was a question that came in about testing. How specific are these tests to COVID-19 versus coronavirus in general?
For the antibody tests or the PCR?
John, could you unmute yourself and ask that question?
I was just wondering if, in general, the PCR tests versus like the antibody tests, because there were some questions at the call center for individuals who said that they previously had coronavirus infection. So I wasn't sure if antibody would pick that up, and some individuals wondering if the PCR test was specific to the COVID-19 or the coronavirus in general. So
the PCR test that's run at the Nevada State Public Health Lab is highly specific for SARS-CoV-2. No cross-reactivity with any known coronavirus.
mm-hmm.
Early on, you heard about problems with the test, and there was a third component once that reacted with bat coronavirus. That was removed. It was a problematic part of the test. You heard all the controversy early on. That's all that was. But the two remaining aspects of the PCR performed by public health laboratories render the test extremely specific and no cross-reactivity with other coronaviruses. Now, antibody tests, we don't have a lot of data on, and it's just by the nature of the speed by which tests are being authorized and developed. I'm familiar with the data, the validation data of only one of the antibody tests, and they say that there's no cross-reactivity with any of the 6 really well-characterized coronaviruses that infect humans, but everybody mounts different responses in a polyclonal means, and so it's still possible that there would be cross-reactivity and we just haven't characterized it. Professionally, my opinion is, and I know this from analyzing PCR and antibody tests over the years, there are a tremendous more number of reasons to be false positive on an antibody test than there are for a PCR test. Almost the only way to be falsely positive on a PCR test is if somebody in my lab makes a mistake, and because of the sensitivity of the test, you can get a false positive that way. PCRs are they're engineered on the basis of specificity. Antibody tests are much more a roll of the dice. And so in any case where you do diagnostics with antibodies, you do run some risk of a false positive.
Thank you.
All right, we're going to go on from here. This was just a little of a bummer of a study out on Annals of Internal Medicine, where they wanted to know whether or not wearing a surgical mask or a cotton mask, not a N95, actually, if somebody coughs, or we worry about these asymptomatic carriers going around, does it actually protect anything? And this is what they had, where they had these 5 people in the hospital. They all had active disease. This is their viral load, the number of viruses in their saliva. So that's the log for, so like 1,000 or 10,000. So then they had people cough on a petri dish that they could then count the number of viruses. And so for example, this patient, he had been in the hospital for 8 days. His viral load in his saliva was 10,000 viruses in a drop. When he coughed onto the petri dish without a mask, he had about 1,000 viruses. They then had him cough with a surgical mask and a cotton mask. And even though they were wearing a cotton mask or a surgical mask, it really didn't provide any protection in terms of stopping the virus from passing through these materials. This is not the N95. And then they repeated coughing without a mask after the control. So they were very disappointed to see that these cotton and surgical masks that we're all wearing really didn't seem to protect anything. And on top of it, they then looked at the mask itself. They looked on the inner surface of the surgical mask, against the person's lip. They couldn't find the virus. but they found the virus all on the outside of the cotton and the surgical mask. So these people are coughing, it's going through the mask, and a lot of the virus is hanging out on the outside. So when people are taking their mask off, they're actually possibly exposing their fingers to it. And so this is sort of disappointing, but probably the best use of wearing these masks is just to remind you not to put your fingers on your face and touching your eyes, etc. So, and be real careful when you remove your mask that you don't hold the outside of the mask. So that was a bummer of a study. But again, it's only 5 people, but they seem to on all the patients they studied, this showed this results. And so I just want to, we'll speed up a little bit here. We want to present 2 patients, one a mild case and one a very severe case of the COVID infection. And just as we've talked about in the last few weeks, it usually has a prodromal period of muscle aches, cough, low-grade fevers. And then about day 8 is when you start seeing the onset of the shortness of breath, and then followed by possibly pneumonia. And the labs that are really important we want to follow are the lymphocyte count, elevated liver enzymes, and abnormal chest X-ray findings. So, you know, when you're first a patient, you're ruling them out for the COVID infection. You want to check the lymphocyte count, look at the transaminases, get a procalcitonin, because a low procalcitonin should be present. The procalcitonin really picks up bacterial infections. And so if it infiltrates of a low procalcitonin, again, that favors the diagnosis of COVID. And so this is probably one of the best markers of the patient's prognosis is their lymphocyte count. So you see here, this is the gray is the patients who survive. The lymphocyte counts over the first few days come down, but after a few days, it starts going up. And in those patients in black who passed away, lymphocyte count continues to fall. So this is a marker again of inflammation and response. Again, as Dr. Pandori was talking, it takes about at least 10 days before the serologic tests start becoming positive. Okay, but the lymphocyte count is a very important prognostic sign. And the X-rays as usually bilateral patchy, infiltrates, there's no effusions. And in China, they're doing CAT scans, but a CAT scan in this country would involve using up PPEs and decontaminating the room. And so it's not really indicated here. And so I'm going to present a mild case, and then Dr. Siddiqui is going to present a severe case. And so, you know, it's very overwhelming to deal with these patients, but I've been thinking of how do you approach a patient who has a possible COVID infection? So there's really 3 questions you want to ask. 1, do they need oxygen? Okay. If they need oxygen, you're going to admit them to the hospital. So then you're going to decide, does this patient have risk factors for a poor prognosis? So then you want to look at the risk factors. If they have any of these risk factors, these are the patients at this point you want to consider adding the hydroxychloroquine. 3, as Dr. Sneakers talked about, do they have laboratory evidence that they have a lot of inflammation, overwhelming inflammation, and they're very high risk for developing ARDS and other complications. So do they need oxygen? Do they have risk factors? If they have risk factors, are you going to start on Plaquenil? And 3, do they have evidence of a lot of inflammation, increasing inflammation, that you're going to be very concerned and manage these people in ICU? So this is an 81-year-old guy. He was brought to the emergency room for shortness of breath. So keep that in your when you're thinking about this patient. Few-day history of fatigue, then on day of admit had shortness of breath, slight cough, and a temperature when the paramedics arrived. So typical prodromal syndrome. His risk factors for infection were none. Again, we're mostly dealing with community infections these days, so it's not surprising that there was no travel, no known exposure, etc. And his past history is positive for hypertension, heart disease, and diabetes. These are, as we'll list again, are major risk factors for a poor outcome. So we want to know, does this man need oxygen? Because then with those past history, we're going to consider him for hydroxychloroquine. So he's mildly short of breath on exam. His pulse ox is 92 on room air, so it's okay. He has a fever. And he undergoes a lab evaluation. But what do we want to look at first? The lymphocyte count, 770. It's under 1,000. It's low. His creatinine is slightly elevated, but he's also an older guy with some issues. His transaminases are normal. So he has a typical presentation. His procalcitonin is 0.09, which is normal. His influenza test was negative. His ferritin, which is a marker of inflammation, is normal, and his CRP is also negative. So we have a guy He doesn't need oxygen, has a typical presentation. He does have risk factors, and he doesn't have markers of inflammation. This is a man you're going to probably put in the hospital, watch him on oxygen and see how he does over the next 12 hours. Does his oxygen requirements go down? And at that point, because he has, as I said, number 2, he has risk factors, it's somebody you want to start on hydroxychloroquine. So these are the patients that are going to benefit the most from antiviral therapy. You know, a healthy 25-year-old is not on oxygen or even has mild oxygen requirements who has no risk factors, he probably has a very good prognosis. But the big ones, 60, hypertension, are probably the biggest risk factors are diabetes, particularly poorly controlled, and morbid obesity. This combination of diabetes and morbid obesity is a very high risk situation. And obviously somebody's immunosuppressed, got cancer, HIV, et cetera, or heart failure risk factors. So these are things that put the people at risk for a bad outcome. And if they do require oxygen or not doing well, we definitely want to jump on getting them on hydroxychloroquine. And if you add hydroxychloroquine, we don't recommend adding azithromycin. What?
Real quick question, 2 slides back.
Yes.
Could you comment on the utility or lack of utility of the kind of getting a viral respiratory panel? You mentioned kind of the flu panel was negative.
Yes.
When you're talking about the labs.
Well, probably the flu is actually sort of going away at this point. We were surprised yesterday with a patient we were sure he had the COVID virus. It turned out to have the flu. And we admitted him to the hospital. We're still suspicious of COVID, but the flu is probably the only test you'd want to do. I think the other test is expensive and it really doesn't add much, particularly because you can have people with more than one infection going on. So just because they have, you know, some parvovirus, something in their lungs, it doesn't rule out COVID. So most people are skipping it at this point, except maybe getting the flu test. And then, so once I said, does this patient need oxygen? We'd watch him for 12 hours, see if he needs oxygen. If he starts to develop it, I said, does he have risk factors for poor outcome? We'd say, yes, he has multiple risk factors. And then we would start him on the hydroxychloroquine, which is the dosing here, the 400 twice a day for 2 doses, followed by a lower dose for 4 doses. But these patients, you have to be concerned. These are older people, could have prolonged QT, and hydroxychloroquine is something you're going to want to monitor. But we do not recommend adding azithromycin because it can exacerbate and interact with their medicines. And there's really nothing to suggest that azithromycin adds anything to the efficacy of this drug. So I'm going to skip this for now. And so this is a renowned hospital has a nice guideline. So let's look at this guy. So this patient's admitted. He's 81. He has, they're going to watch him. If he's improving, just continue to watch. But no, does he start to need oxygen? Let's say a few hours later, he's now on 1 to 2 liters of oxygen. We say yes. Does he have the risk factors? We say yes. He's 65. He's got hypertension and diabetes. So then we'd go down yes, and we'd put him on hydroxychloroquine. Okay. So if he's young, he's not needing oxygen or barely needs oxygen, and doesn't meet any of these criteria, we would just continue supportive care. Obviously, if they get worse, things would change. But that's basically approach renowned, and I think it's a good approach to these patients. So I want to have Dr. Siddiqui present the other spectrum of this disease.
Thank you, Dr. Krasner. So hi, I'm Faisal Siddiqui. I'm a pulmonary critical care physician here at Reno VA. So I'm going to talk to you about the other spectrum of the disease with which these patients can end up in the hospital with. And this is a patient that recently admitted to the hospital, 54-year-old, was admitted with respiratory failure. It was a pretty remarkable respiratory failure, was hypoxic at home for about 40% on room air. When the ambulance squad reached the home, they found that the patient was requiring 15 liters of a non-rebreather. The risk factors were she was exposed to COVID-19 case a week earlier, where one of the patients, he was a healthcare worker, and one of the patients he was taking care of had COVID positive disease. Not many risk factors, medical history-wise, was just obese. So history of presenting illness was complaining of non-productive cough for a few days, sent home after COVID testing was done, and then test reported was positive, so was appropriately quarantined, but then become quite short of breath at home, and then was brought into the hospital. She was emergently intubated and emergently required 100% oxygen. So this is kind of a thing that you need to realize, is that the presentation is quite variable. The patient Dr. Krasner presented had risk factors for a very bad disease. And this patient, on the other hand, not had a lot of epidemiological risk factors, for example, obesity, diabetes, high blood pressure, things like that. But she progressed really rapidly. Admission labs showed an influenza testing that was negative. WBC count was 4,000, with the lymphocyte count was 480. So that is really very consistent finding across board is this lymphopenia. Then there are some inflammatory markers like CRP, D-dimers, and ferritin that also have a quite significant prognostication value added to them. So they're not just showing you that there's a huge inflammation going on, and I'm gonna tell you guys more about inflammation in these patients, but also they have prognosticating ability, and patients who have these values abnormal, they do fairly poorly the beginning. One of the other things that are consistent in our observation was persistent elevation of AST and ALT. Procalcitonin is usually a marker of bacterial infection, is usually negative in these patients. So, and this is what I would like to tell you more about, and this is an overwhelming proportion of these patients who are admitted to the hospital, they develop this cytokine syndrome. And this is just like a bomb just went off in their bodies, and it just runs havoc. And so basically, all these cytokines, as a result of this inflammation, cause injury to the patient's own body. And there are risk factors that actually can predict who's going to develop and who's going to not. So as you can see in Dr. Krasner's patient, he did not really have an elevated CRP or D-dimer or raised ferritin levels or LDH, and which are very good inflammatory markers of developing a cytokine syndrome. But in this patient, they were significantly raised, and this is a patient who's going to definitely benefit from this anti-interleukin-6 antibody that we have utilized in this patient as well. And that actually blocks interleukin-6 receptor, and it probably helps us in lessening the effect of this cytokine syndrome. It is used as an anti-cancer drug in children and some other older people, but this is definitely something that we are using it for a reason totally different. So convalescent plasma is definitely something that we are thinking about in utilizing, especially in very severely sick patients. And convalescent plasma is basically plasma derived from a person who has recovered from the illness. And I'm actually still trying to wrap my heads around what would be the definition of person who recovered. And some people say it's 14 days after having a negative nasopharyngeal swab from the onset of symptoms, or some people say maybe 28 days. But I think the jury is still out there. We have used convalescent plasma in previous pandemics, and there are individual case reports that came from, I think this individual case report was in China, where patients came in. It's a case series of 5 critically ill patients, and they have remarkable improvement. And I think 3 of these patients were actually ended up being discharged home, and 2 of these patients were actually doing well at the time of writing of this case report. And there are some other case series and case reports that actually showed that convalescent plasma is something that to always think about. And we are actually in the process of getting authorization for convalescent plasma. There is a meal clinic protocol that you can enroll your patient into. And there is another way that we are doing through Vitalant Lab. The VA hospital has recently got a contract signed by the lab so that we can utilize convalescent plasma for some of our patients.
Thank you, Dr. Sticky. The way to think about this, one, you've seen your patient first, do they need oxygen, okay? If they need oxygen, you're gonna hospitalize them. If you're gonna hospitalize them, do they have risk factors, as we talked about, morbid obesity, diabetes? And those are the patients who are older age, are the ones that are more likely to have a bad outcome. And then you'd want to start those patients on hydroxychloroquine. Then when you're admitting those patients that who are going to be on a hydroxychloroquine, get some baseline inflammatory markers. Look at their ferritin, look at their D-dimer, the LDH. And if those are rising, CRP, if those are rising significantly, be very concerned about the development, this is what we call that cytokine storm that we saw in this patient. And those are the patients you may want to get in the intensive care unit and consider some of these agents if it's available to you. So I think that's a good way to look at it, these patients, but they're very challenging for sure.
Great,
So
thank you, Dr. Krasner and Dr. Siddiqui.
yes.
I think we'll move on now to questions. So there's been a number that have come in through the chat box, so we'll start addressing those. And feel free to keep writing in those questions, and we'll get to those as they come in. So a question from Dr. Kathy Eckert, who actually serves on one of our other ECHO teams for our complex pediatrics clinic. If you're interested, that clinic meets tomorrow at noon. We're going to have a presentation on skin cancer prevention for the school age population. So lots of things available through Project ECHO Nevada. So her question is, are asthma and COPD considered risk factors?
So there is no data that has actually shown that asthma or COPD being the risk factors for this disease, but we know for sure that any patient who has chronic lung disease do not do very well when they, of course, develop ARDS. So the answer to this question is basically if somebody has chronic lung disease, they are likely going to do poorly once they get this infection, but are they at higher risk of developing this infection is not understood yet.
If they want to get plaque on those two.
Correct.
Sorry, Charlie, we missed that. Could you say that again?
That's a significant risk factor, and so definitely want to put them on hydroxychloroquine.
Okay, so there's actually a question here about hydroxychloroquine. So CDC removed its guidance on hydroxychloroquine dosages. Are you still placing suspected COVID patients on this therapy?
Yes. I don't, sometimes as a doctor, you got to feel like you got to do something, okay? Despite what our president says, the evidence is still out there. Most of the studies from China were very poorly done, and they just do everything at every patient. So it's really hard to tweet out what effect the hydroxychloroquine did on these patients' prognosis. So we just don't know.
What we're doing is at Renown weighing the risk versus benefit. We know that there are toxicities associated with hydroxychloroquine. We have absolutely no idea if it's going to work. And so in patients that are at higher likelihood of an adverse reaction to hydroxychloroquine, we're not using it. And honestly, it's up to physician dependent. Some physicians have really bought into use of hydroxychloroquine, others haven't. There's not, you can't make a definitive recommendation because there's no evidence to support it one way or the other.
Yeah, so that's real important to look for cardiac issues with your patients. They have the QT prolongation. What are some of the meds that can increase your QT prolongation to begin with? Jessica?
Say again?
What medicines would you be concerned about patients being on that could affect their QT prolongation to begin with?
Sure. I mean, azithromycin is the one that we most commonly see because they're being admitted for pneumonia, and it's the preferred it's in the preferred combination for treatment of community-acquired pneumonia, but also your antiemetics, Zofran, compazine, promethazine can all cause a prolonged QT interval. So we're really minimizing the use of those in patients that are admitted. The any kind of antipsychotic, tricyclic antidepressants, all things to think about when you're starting hydroxychloroquine. The American College of Cardiology has an excellent document on the recommendations for monitoring patients started on hydroxychloroquine for COVID-19. They actually recommend the QT monitoring be done by a cardiologist. So we're recommending getting cardiology involved in every case that started on hydroxychloroquine for COVID-19.
Another question here, why are we avoiding NSAIDs in patients while giving them supportive care?
There's no Dr. Fauci says there's no evidence, but he says he prefers Tylenol for fever control. It's one of those Twitter versus things that go on, but there's no evidence to support that.
Okay. How long is disease transmissible after resolution of symptoms?
So this is one of the other things that we are looking at when we are utilizing convalescent plasma. And we know that once patients are symptom-free, then after 14 days, they're probably, not going to spread infection. But of course, this is going to vary from patient to patient. And for getting convalescent plasma, we're actually requiring them to be having a negative nasopharyngeal swab and then counting 14 days from that point. So I think, to be honest with you, once patient is asymptomatic 3 or 4 days down the line, it's very unlikely that they will be transmitting any virus at all. And this is what the guidelines, most of the guidelines say, but I would say that 14 days is a very good time limit for most of these patients to become non-infectious.
Thanks, Dr. Siddiqui. If we do end up having to intubate these patients, what PPE should be used during that procedure? I've heard that I've heard to have PAPRs for everyone in the room.
So this is a very good question, and we are looking into devising some protocols here at our VA as well for these patients. And so when you are intubating, intubation is considered a very high risk procedure for aerosolization. And we are recommending that the person who is intubating is completely donned in a PAPR or an N95 along with double gloves, non-water permeable grade 3 surgical scrubs, or any other bunny suits that we can get which have a good ability to stop any transmission of droplet disease, and have a face shield. So doing PAPR is probably beneficial because it has a face shield at the same time. And then you have basically something to cover your boots as well. Once you have these precautions, you use a video laryngoscope and not do a direct laryngoscopy on these patients as well. And with video laryngoscope, there should be the most, there has to be the most, experienced person to do this procedure at that point to come and do it. And then we are also recommending that all the people who are inside, we have to have like minimum amount of people to preserve our PPEs. But if you need a respiratory therapist to help you place the patient on the vent, and the nurse who's giving the medication, they all should be donning N95 or PAPRs.
Great, good question. Dr. Warko.
Yeah, thank you. That was really helpful information.
Thanks, Dr. Warko. All right. Shouldn't steroids theoretically help with the cytokine storm?
So corticosteroids have been looked at in COVID-19 patients. Steroids have been looked at in ARDS for a very long time. And the simple answer to the question is we don't know whether they work or not. We do not really have a great evidence. Our society suggests that, once the patient is in severe cytokine syndrome, to use it, but the evidence that this recommendation is based on is very weak. The patient that we discussed in question, the second patient, of course, was given steroids as well to manage her cytokine syndrome, but she didn't really do very well.
Okay. So I know we are already over time, so if you do need to take off, but you want to claim your CME credit for today, I sent out the link for that evaluation through the chat box, but we'll be here for as long as you have questions. So we'll go on to the next question here. Is there any information regarding azathioprine in blocking the cytokine storm in patients with a history of Wegener's?
So azathioprine is an immunosuppressive drug that is used in many different conditions, including granulomatosis with polyangiitis and some other vasculitides. It's also used in autoimmune diseases. It's also used in chronic fibrotic lung diseases. But I would not consider giving this to a patient who's presented with COVID-19. There is no evidence to suggest its use has improved outcomes or anything. So definitely, I'm not going to consider azathioprine as a modality to fight the cytokine release syndrome in these patients.
Question about testing. 2 negatives assures that there won't be any transmission. Is that correct? 2 negative tests in a row.
I think it certainly improves the chance that they're not contagious or don't even have the syndrome. The Nevada State Lab is an excellent lab. They know what they're doing, and if it's 2 negatives, then I think you feel pretty reassured about it. They do have you, if you do seem symptomatic but early, they will have you come back in 1 to 2 days for another test, and if that's negative, you'll be fine. But you'd probably, if you're symptomatic for whatever reason, you probably want to stay home.
It also depends on when was the test taken, right? So if somebody is having symptoms on the day one somebody was tested, then they still have a chance that they're false negative because there's not enough RNA or virion particles in the nasopharyngeal swab specimen. But if they are having fevers 4 days in a row, then if the swab was taken on the 4th day, then the chances of that being negative are pretty falsely negative are pretty low. Yeah.
I should have clarified the question. This is a person who's already positive, already sick, discharged, and after that, 2 negatives after being positive with 24 hours apart would pretty much reassure that this patient is not transmissible to the family.
So our employee program is that they have to be asymptomatic for 5 to 7 days, and then they get 2 negative PCRs, and then they can return to work.
Thank you.
Thanks for the question, Dr. Bayan. We had a question that came in last week. It was seeing anecdotal evidence that treating these patients as having ARDS may not be appropriate in all cases, as they often have high lung compliance. Any updates on vent settings, recommendations for initial intubation/ventilation?
Okay, this is a very interesting question, and I'm really surprised because actually, so let me tell you about this disease. So this is a severe ARDS that happens very quickly, guys. These patients, they go from needing 2 liters to full-blown ventilator requirements within 48 hours or 72 hours. So it's a pretty rapid deterioration. And then their lung compliance is actually pretty poor. And I know what the gentleman or the lady who's asked this question is coming from. I think that these patients, they require very high levels of PEEP, and they require a very low tidal volume ventilation strategy. They often require paralysis or proning, and I'll come to that in a second. What does these things mean? Yeah, so basically their lung compliance is very poor. Now there was some data coming from Italy and earlier on, which actually showed that they actually may have very good lung compliance. And one of our huge people in pulmonology by the name Dr. Gattinoni actually wrote a nice editorial about these patients having very good lung compliance and may not require this. But to be very honest, I have not been experiencing this. From the data I have seen from the patient I took care of, they have extremely poor lung compliance. Yes, there are people who are saying that they may have good compliance, but overwhelming majority is actually of the opinion that they have extremely poor lung compliance. The Society of Critical Care Medicine has actually issued guidelines of initiating paralysis, because we knew that paralysis was out last year after the ROSE study that showed that paralysis has no benefit in ARDS patients. It was a good study done here in the United States, but now our society is actually recommending starting these patients on paralysis, which basically means you won't paralyze a patient who has good compliance. You only paralyze a patient who has very poor lung compliance. So I do not agree with the notion that these patients have very good lung compliance.
Thanks for addressing that. Question here, thiamine deficiency can mimic many of these symptoms, and many of the affect are a high risk of already being deficient. Are you aware of any research about patients' nutritional status during COVID infection?
So thiamine deficiency does not give you fevers. If somebody is having very high fevers and infectious etiology, and they are basically not so I don't really think that thiamine deficiency necessarily puts them at a higher risk or not, but definitely patients recovering who have thiamine deficiency, they're very sick, they're nutritionally deficient, and thiamine deficiency is basically a marker of their being nutritionally deficient anyways. So these patients do not do very well once they are intubated. Is there any relation between thiamine deficiency and this disease? I don't really think this has been documented or shown anywhere.
Thanks, great questions. Are there any other questions? I haven't seen anything else come in through the chat, but we're still here, so happy to help you with anything. Feel free to unmute yourselves, please, with the little microphone icon in the lower left corner of the Zoom window, or use that chat box.
You hear me, Troy?
Yeah, go ahead.
Yeah. If people have questions, don't wait till this. They can call me and I can get a hold of Dr. Siddiqui, or they can ask me. I mean, if you want anything about management of the ICU patient, Dr. Siddiqui's your guy. So feel free to call us. We want to help.
Yeah, thanks, Dr. Krasner. I will send his phone number out through the chat box right now, so you can contact him with questions in between these sessions. All right, I don't see any other questions coming in and nobody unmuting themselves, so I think we'll wrap up for the day. Thanks so much, everybody. This was a great session. So glad to have so many of you joining us. We hope you'll join us again for our COVID-19 update next week, though. Take care, everybody. See ya.